So let us talk about how to prepare a patient for colonoscopy who has come in with massive low LGI bleed and who was unstable. The first step is to resuscitate the patient, and here the patient, when he came in, was unstable with a heart rate of 120 beats per minute, blood pressure of 95 by 60 millimeters of mercury with otherwise adequate oxygenation. So the first priority in any bleeding case is to resuscitate and make the patient hemodynamically stable. So after a few hours, as you can see, his blood pressure has come up and his hemoglobin also has come up, and the bedside nurse calls you and shares with you that the patient has become stable and has not had any further bleeding. In that situation, once the patient is hemodynamically stable and is able to take the preparation, we should plan and start the colon cleaning prep or colon cleansing. And when it comes to colonoscopy prep, unlike elective colonoscopy prep, here we prefer to use polyethylene glycol electrolyte solution, anywhere between 4 to 6 liters, and one should drink that in 3 to 4 hours. And that rapid purge is the one that clears the colon of all the stool and also all the blood. And that is very important to make sure that the nurse at the bedside should be checking and make sure that the colon output or the rectal output is clear of blood and clots, and once that is achieved, then they can go for colonoscopy. However, when we uh, ask the patients to drink the liquid, that amount of liquid, some other patients may not be comfortable drinking a large volume of liquid very fast, and they may not be able to tolerate. And in that situation, what are the options? In that case, in somebody who is not able to drink, one could offer the possibility of placing an NG tube and giving the electrolyte solution through the NG tube, again at a fast rate. It's important to keep the patient semi-erect because these patients are at aspiration risk. And if the patient is not able to tolerate the rapid purge, one could consider the possibility of writing IV Reglan to allow the stomach to empty faster. So once the nurse looks at the output, the colon output, and finds that it is clear of all the clots in the stool, then they inform the endoscopist who arranges for the emergency colonoscopy. And usually you need to wait for at least 2 hours for the liquid to empty before you could consider emergency colonoscopy. Some centers may want to wait for a little longer, and because of the risk of aspiration, some centers may decide to intubate the patient and protect the airway with an endotracheal intubation. So what we have learned here is two important points. You start the resuscitation of the patient first. Make sure that the patient is hemodynamically stable before you write the colon prep or before you start the colon prep. When it comes to giving the colon prep, the ideal solution is a polyethylene glycol electrolyte solution. The volume typically is between 4 to 6 liters and maybe a little more until the affluent is clear of all the stool and clots. If the patient cannot tolerate the drink, one option is to place a small bore nasogastric tube and giving that fluid with the help of intravenous metoclopramide if need be. And once the affluent is clear from the rectum, after 2 hours, they should have the colonoscopy. If it needs to be done earlier than that, they should have endotracheal intubation and protection of the airway. Although there are some recent studies showing the benefit of a smaller volume, this is something that is this field is evolving, and you should keep an eye for that smaller volume with a special formulation that might be helpful. I hope this is helpful. Thank you.